Good. I think we're live now. Can you hear me at the back okay? Great. Well, good morning and welcome to our Patient and Family Day on Neuromyelitis Optica. I've lost track how many of these we've had. I think this is 4 or 5 since we started the program years ago. And I was saying to some of our new speakers that this was the first, I think still the only program in Canada specifically for NMO and NMO spectrum disorder. So thank you for taking time out of your Saturday to be part of this. And we've built the day so there's lots of opportunity to interact with each other and to interact with some of the faculty. Usually I'm so loud.
No, not today.
Not today? Okay. So we've got a great faculty. The design of the day will be some overview presentations with opportunity to ask questions in the morning. We'll have a group photo for those of you who want to participate in a photo just before lunch. Then after lunch, we'll have 2 breakout sessions where, again, it tends to be more interactive, where the content is driven by you, what questions you have. So there'll be one session in Cantonese and Mandarin with myself. I've been working really hard on becoming bilingual, so but I will have help. And a session in English with Rob Crothers. So that'll be out in the foyer after lunch. And so for those of you that like to stay and have more of an interactive discussion, please stay for that. And so, and again, just a bit of housekeeping. Washrooms are just out and to the right. We've got them unlocked. Thank you, Michelle, for getting those unlocked. If more washrooms are needed, there's some just outside the clinic, which is a level above. I've got those doors unlocked as well. And yeah, so without further ado, I'll get into a few slides of introduction that I had. So when you tell people about NMO, not many people, including doctors, understand what NMO is. It's a relatively rare disease in Canada, in contrast to diseases like multiple sclerosis and strokes, which everybody knows what a stroke is, everybody knows what a heart attack is, what multiple sclerosis is, but not many people will know what NMO is. And it's an old disease. It was described in the 19th century before MRIs and blood tests existed. And was described by a French neurologist and his student, Professor Djavad. And previously, this disease was called Djavad's disease. And then it's kind of been rebranded as Neuromyelitis Optica, and then as Neuromyelitis Optica spectrum disorder. And the reason that the name was changed to spectrum disorder is because not everyone who developed this disorder fit into the exact same profile that Djavad described. So what Djavad described was losing vision and losing mobility within a week or 2 of each other. So a very rapid combined syndrome. And what we've discovered since then is there's quite a range of how this rare disease can affect people, from just affecting vision to affecting mobility to affecting nausea and vomiting. And so the NMO spectrum disorder, broadening the title, acknowledges that it's a broader disease. And what's really been revolutionary in diagnosing the disease is having access to the antibody test for this disease, although not everybody who has this condition will be positive for that antibody. It's a good test, but not a perfect test. So things have come a long way since the 19th century when it was first described. What causes NMO? It's the big scientific and mystery question, but it's the same question we have for what causes lupus, what causes rheumatoid arthritis, what causes multiple sclerosis. The concept is it's a dysfunction of our immune system, and our immune system is there to protect us from viruses and toxins and bacteria. When we get a series of immunizations as a child, we're training our immune system to be a rapid reaction force to common viruses or toxins such as tetanus. And so it's a very elegant system. These are our white blood cells. So when we do a blood test looking at our blood, looking at hemoglobin as our red blood cells and looking at the white blood cells as our immune system, we can't on the surface detect an abnormality in that. But there's a small portion of those cells that have made a mistake, and instead of protecting us from infections are now damaging our bodies, and that's called an autoimmune disease. And why that mistake has happened is unknown. There's a lot of different theories, and that'll be a Nobel Prize when that's figured out. And there's a lot of research, international collaboration with NMO to try to determine why that happened, and perhaps someday have an immunization against future NMO would be lovely. Our goals in our program that we started several years ago was to educate physicians to be aware of this disease. And that's been enormously successful. We found a big challenge that this condition was being called different diseases. It was being called multiple sclerosis. It was called Asian MS. It was called ADEM, a whole variety of different names. And people weren't being triaged and treated in the way we thought they should be treated. And so we've done a lot of outreach to physicians around the province and around the country and around the world to try to raise the awareness of NMO. And it's been very successful. Vancouver has one of the largest training programs for neurologists in the country. And all of our residents, our neurology residents, spend 3 months at our clinic. And we're generating a new generation of neurologists that are aware of NMO as well as MS. And we've been seeing the advantages of that. Now, I've been getting calls from some of our former students that are working at the Royal Columbian and Surrey Memorial Hospital, now in Abbotsford, saying we've found somebody we think has NMO. So they're thinking NMO and getting people diagnosed much more rapidly. Instead of a 5 to 10 year delay, it might be a 5 to 10 day delay. And that's, to me, is an incredible accomplishment. We're also trying to raise awareness in the public. We have outside an article that was published in Reader's Digest. My finest moment as a Canadian, being published in Reader's Digest, having grown up with Reader's Digest. I don't know if the younger generation still reads that, but for me it was a proud moment. And that was the first time Reader's Digest did an article on a medical condition, and they chose NMO. And I think that's going to be very helpful in raising the general public awareness. So education's a big component of what we're trying to accomplish. And providing medical care. Fortunately, we've been able to base ourselves out of the multiple sclerosis clinic, where we can leverage off of the resources of the nurses and administrative staff. Yes, I know we're understaffed. It kills me. We want more nurses. We need more nurses. Please advocate with your MLA that we need more resources to provide care so that your phone calls are answered promptly. But providing improved medical care is a big component of what we hope to do and wish to do and aim to do. We've got wonderful fellows at the back of the room. I think I saw Philippe, Emmanuel, and Jillian, who are all working with us and providing rapid access care for any relapses as well. So we're very, very fortunate to have this team. And finally, one of our mandates is research. We've got a great research team trying to understand this disease. We're involved in international collaborations. We've got a very interesting collaboration with colleagues in Korea, trying to develop a way to distinguish NMO from MS earlier with MRI and using a computing science technique called machine learning. And if I could have, we have a lot of trainees and researchers here. Could everyone stand up who's a researcher trainee? Emil's already standing up. And Phoebe's one of our coordinators as well. So we've got a great team of very bright, very energetic people involved in the research as well. We cannot do this without support, and we would like to acknowledge all the wonderful people who, from their heart, have dedicated their time and energy into supporting a rare disease, so that we can support students, we can have educational events, we're just incredibly grateful to that. A lot of stuff goes on behind the scenes, and in order for us to do that, we need the resources. And we don't have provincial funding. I don't know how to get provincial funding to run this. If anybody has ideas on how to get provincial funding, please let me know. But otherwise, we are doing this in our offices, and I think doing pretty successful. So I know we're running late, but that's how these days go. Without further ado, it's a great pleasure. The faculty we have today to speak is wonderful, but our first speaker is Janine Mickelson, who's a urologist, both pediatric and adult urologist. I'm a neurologist, and she's a urologist, and such an important aspect of care. And thank you so much for taking time out of your Saturday to share your thoughts on bladder management. So I'll get your slides.
Hi, everybody. I think that's a very important designation, is urology versus neurology. So I am the urology end, and some people may say, what is a urologist doing at a NMO day? And the answer is that I actually see a lot of patients with NMO and MS, and I'm going to be generalizing a little bit. I recognize that they are two very different disease entities, but from a bladder standpoint, they actually can come across pretty similarly. I did do a fellowship in pediatric urology, but also do a lot of what's called functional urology, where we look at lower urinary tract function and dysfunction. I work over at the Bladder Care Center, which is on the first floor of UBC Hospital. Some of you may or may not have been there before. And I see a lot of MS patients and NMO patients over there. I also work out in Richmond at a practice called Metrovan Urology. So did I just pee? This is a question that people find themselves asking sometimes, not always with NMO and MS. When I was putting these slides together, I wasn't sure exactly what the group would want. And so Tony had given me a list of topics, and I sort of thought, well, rather than just talking about one of those things, let's talk about all of them. So I'm doing questions and answers about the bladder and NMO and MS. So the goal of this talk is to list common concerns regarding the bladder and multiple sclerosis and NMO, and discuss management alternatives for those disease entities, so you have some ideas of what to do. So these were the questions I was given. How common are bladder problems in MS? Why doesn't my bladder work? How do I know what's happening with my bladder? What are some non-medication options for bladder management? What are some medication options for bladder management? What happens when the medications stop working? Is there something else to do? And what about bladder infections? I'm going to do my best to try to go over all these things. So bladder problems in MS, this is a very common thing with MS and NMO. 3 out of 4 patients with this disease entity will complain of some sort of bladder symptom, whether that's urgency, frequency, bladder infections, retention. There's a whole spectrum. 1 in 2 patients will have issues with exactly what I was just talking about, urgency, frequency, incontinence. And 1 in 4 will have retention. So there's a real spectrum as to what can happen with your bladder. Retention, leakage. In order for me to talk to you about this today, you have to know how the bladder works. And basically, the bladder is a pretty simple thing to understand. There is the bladder muscle, and there's what's called the outlet. So the bladder and the outlet. The outlet holds the pee in. When you relax the outlet, it'll let the pee out when the bladder contracts. In terms of really the most important part is actually not what's called the lower urinary tract, which is the bladder and the outlet. It's the upper urinary tract, which makes your pee, which is the kidneys. And that's ultimately what we're trying to protect. Although it's the lower urinary tract that gives us all the grief, the leakage, the urgency, and the frequency. So again, the bladder, the outlet. So question, why doesn't my bladder work? Well, you have to look at the bladder and the outlet. So in terms of if you have failure of your bladder or the bladder to store urine, what you get is overactivity. And you perceive that as urinary urgency. And what urgency is that feeling of like, oh no, I'm putting my key in the front door and I'm not going to make it to the bathroom. That's urgency, okay? Not feeling like you can make it to the bathroom without wetting your pants. Incontinence is leakage of urine. So urgency sometimes results in incontinence, but not always. People can have urgency without leakage. So failure to store, that's at the bladder level. What happens when you're failing to store at the outlet level? Well, sometimes the outlet just isn't strong enough to hold your pee in. And that's called sphincter deficiency. That also can result in incontinence. The other aspect is for patients who have failure to empty the bladder. And that's when either the bladder muscle doesn't contract and empty, or the outlet muscle fails to relax. So those two things can go on. And this can be as a result that the bladder muscle just doesn't have any power anymore. We call that a hypotonic bladder or an atonic bladder. Or that the outlet is just chronically tight. and not relaxing, and so people can't actually get the pee out. Well, how do you know what's going on? All that you know is that something is crazy going on with your bladder, and sometimes you're feeling like you have to go pee 20 times a day, or other people feel that, oh my goodness, I can't pee at all and I need to something to drain my bladder. In terms of figuring out what the problem is, all patients, I feel, with NMO or MS should have a urologic evaluation, ideally, eventually by a urologist. And that involves, going through a history about what the urinary symptoms are, having a physical examination, and then doing certain tests, because ultimately, we want to try to protect the function of the kidneys, which makes your pee, but also the function of the lower urinary tract. So how well the bladder is working. Because if the bladder is chronically distended and full all the time and getting stretched out, it's not going to work very well. So we do things like kidney and bladder ultrasounds, kidney function tests. Sometimes we look inside the bladder and the outlet to see what they look like. And we also do studies called urodynamic studies. And that's actually a filling and emptying study that looks at the power of the bladder and how much power it does have or doesn't have, and if it's actually trying to contract when you haven't given it permission. And that's when you feel that urgency and overactivity. So what can you do about this even after today? Like if you go home today, is there anything you can do for your bladder? And there is. A lot of people don't know how many times to pee in a day. A lot of people think that the less you pee, the better. In fact, there is sort of a perfect number. Ideally, people pee about 7 times a day. The bladder likes to cycle, and notoriously, people tend to hold. And so ideally, you want to cycle your bladder every 2 to 3 hours, and especially a bladder that's had neurogenic change to it needs to be, it likes habits. It likes patterns is sort of what I tell my patients. So whether you feel the drive to pee or not, ideally you should cycle your bladder every 2 to 3 hours. The other thing that you can try if you are retaining urine is what's called double voiding. So that's where you void or pee, you wait, count 5 Mississippis is what I tell my pediatric patients, and try to pee again and see if any more pee comes out. Things that irritate the bladder can often make these symptoms worse. So all the fun things in life, caffeine, alcohol, spicy foods, those are things that can set off your bladder, right? So if you enjoy your spicy Thai food, that's okay. But just know that maybe the next day things might be a little twitchier. I could almost give 3 talks entirely on the management of constipation. Constipation is so critical. If you treat your bowels, often your bladder will get better. So it's very critical that the constipation is addressed. Bowel management is an art. It's even more of an art sometimes, I think, than the bladder management because it's very, very difficult. And I talk with my patients about managing their bowels because everyone is a little bit different as to how best to do that. Another conservative thing which has shown really promising results is pelvic floor physiotherapy. So a lot of patients are like, you know what, I'm taking lots of medications, I don't want to take any more. What else can I do? And this is something that you can self-refer yourself for. And we've actually seen improvement in urgency, frequency, and incontinence of upwards of 60 to 70%. So now, this is all comers, not just MS NMO patients, but patients with MS and NMO will have benefit from pelvic floor training. And again, you've avoided any medication. So what about medications? What can you take for your bladder? Again, this would be sort of under direction of a physician of doing a urologic assessment of some sort, not necessarily a urologist, but let's say that you've been in to see your neurologist or your family doctor, and from the symptoms, it's evident that likely you have overactivity in your bladder. There is certain medications that you can try and see if it helps. Now, if you're a patient that's in significant retention and you're not having issues with overactivity, which is urgency, frequency, leakage, this isn't really what's going to help you, okay? So if you're a patient that's retaining and are having trouble emptying, this isn't sort of what the goal is. This is for patients who are experiencing urgency frequency. Now, I have a lot of patients that have urgency frequency and retention. So you have to kind of work with each individual case and try to figure out what's going to work for you. And often we try things just to see what happens. And usually there's a decrease of urgency frequency perception or experience by about 30 to 40%. So often really bothersome symptoms, for example, having to get up at night to go pee. So if you're getting up 3 times at night to pee and you're going down to 2 times, that's pretty good, in the sense that patients, if they're able to get more sleep, that's meaningful for them. So for every patient, it's different. What happens when medications stop working? So there is more. There is other things to try. And the first one on that list has been a game changer for patients with MS and NMO. Botox injections into the bladder result in a significant decrease in urgency frequency. And you usually get a response rate of about 70 to 80%. And for patients, I do Botox on MS patients weekly, probably about 2 patients per week when I'm out at the Bladder Care Centre. And I've yet to have one that isn't totally insistent on me repeating it. So every patient that I know that I've done that on has wanted it again. The nice thing is right now Botox is covered by the province, so it's something that you can get coverage for. I'm going to speak a little bit more about Botox, I think, in my next slide, so I'll come back to that. Neuromodulation is another option if you're not wanting to do Botox, and I'm going to review that. The other option, too, is if you're in retention or if you're having a lot of overactivity and leakage, is to talk about catheters and what the options with catheters are. A lot of people look at me and go, when I say the catheters, but I have had catheters improve the quality of people's lives significantly. So Botox. Botox is injected into the bladder through a scope. So I look inside your bladder, you're awake, we do it at the Bladder Care Centre, through a tiny, tiny little needle, and there's about 10 injection sites. This reduces urgency frequency by, like I said, by about 80%. Average duration of action is about 6 months. So you do have to repeat it. So it's not the type of thing that you do and you're done with it. Most patients come it's roughly every 6 months for an injection. And again, right now, provincially, it is covered if you've failed other oral medications, and it really is an excellent option. Posterior tibial nerve stimulation, we also do this at the Bladder Care Centre, which is next door. It's where we actually stimulate a nerve in the leg, the posterior tibial nerve, which communicates with the same nerves that go to the bladder. And what this does is improve urgency frequency through crosstalk between the nerves, essentially inhibition. And again, I've had MS patients with significant improvement, even patients who Botox wasn't working for them. I had one patient said it made a significant difference for her. The issue with a posterior tibial nerve stimulation is a bit of a commitment, but you have to come sort of once a week for 12 weeks to have the stimulator placed for about half an hour. But again, it's another option. What about catheterization, the C word? Unfortunately, there's no medications or surgery that we can give you to make the bladder contract better. We can't make the bladder stronger in terms of its muscle. So as a result, when people have a bladder that doesn't have power anymore, so what we call a hypotonic or an atonic bladder, we have to figure out a way to empty their bladder. So we do the time voiding and we do the double voiding and try to optimize things as best we can, and sometimes that's not enough. In that case, we'll often train patients, and they get trained at the Bladder Care Centre, how to put a catheter in and out. And believe it or not, I know a lot of patients, when I first talk to them about this, their eyes go very wide and they look at me like I'm crazy. But I've had patients that have found it to be essential for their life and have provided them a lot more control. Often, for example, they'll catheterize themselves before they go to bed at night, and then they sleep through the night because all the urine is finally out of their bladder. Some patients will catheterize themselves 4 times a day. Some patients catheterize themselves once a week. So it really is variable as to how much you use that tool. Another tool is to have an indwelling catheter. And again, that depends on mobility issues, on care issues. I also have patients that use indwelling catheters for certain things like going skiing, so that they don't have to take all their ski gear off and get to the bathroom. So there's all different scenarios as to what can work for you. Another option too is a catheter that, instead of coming out the urethra, which is down below, what's called a suprapubic catheter. So there's many different things to consider and choose from. So infections are a common problem for patients that retain urine. And what happens is you retain urine and your pelvic floor tightens up, the bladder doesn't cycle, you get this stasis, and it's not clearing, and the infection occurs. And then it's very hard to clear the infection because you have this residual urine in your bladder all the time and you're not flushing it out. Also, some patients that catheterize themselves will have bacteria in the urine. That doesn't necessarily mean infection. Patients are what are called colonized with bacteria, and if it's not causing them any harm, in other words, not giving them symptoms of a bladder infection or a fever or blood in the urine, then we don't necessarily have to treat all those bacteria. But we have to think about these things in MS patients. Now, some MS patients experience real flares when they get symptomatic bladder infections, and so sometimes that is a reason to treat preventatively. So every patient has a spectrum, again, for this type of problem. What can you do to limit the infections? Time voiding. So in other words, cycle your bladder, double voiding, constipation management. Obviously going along with these things is water drinking, right? To drink an adequate amount of water. Cranberry and D-mannose, there is some evidence, but very limited evidence for its benefit. I use it for my patients because we're trying everything that we can to try to minimize infection, and I've had yet to have a patient have a bad side effect from cranberry tablets. D-mannose is a sugar that prevents bacterial adhesion in the bladder. So again, a conservative homeopathic thing to do for infection. Probiotics, was excellent evidence to show decreasing negative side effects of antibiotics, but by upwards of 40%. So if you're needing to take antibiotics for infections, for sure take probiotics. Also for recolonizing healthy bacteria in your bladder, it's critical. Also to think about vaginal estrogen for women who have gone through menopause. This is often an effective technique for preventing infection. So when we look at the whole picture, there's only one square that you see up there that's really medication or intervention. There's a lot of very conservative things that you can do that are effective. And I think it's really important to remember that. So to wrap this up, I think important things to think about for patients who have NMO or MS is, do you need to think about your urinary tract? Is your urinary tract bothering you? Is your bladder bothering you? Are you experiencing urgency, frequency, leakage, retention? And if that's the case, make sure you at least mention it to your neurologist or family physician, because then you could get along to, or sent along to see a urologist if need be. Conservative measures work. Don't underestimate them. It really does make a difference. If you're only having a bowel movement once a week, your bladder will reflect that. So things like that are important to address. And there are many options, so both medication and non-medication options. So don't think, I've had a lot of MS patients come to me and say, well, I thought this was just MS, like this is just the way it is. And in fact, that's not the case. So it's really important to realize that there are some things to try. And the reason why I put this up, metrovanurology.com, is that we write all the content on our website. And I've written a section on the metrovanurology.com website under urologic conditions on MS. And so a lot of the things that we're talking about today, treatment options, medication options, are written on the website here. So if you go, again, under urologic conditions, under neurogenic bladder, there's a section on MS. So yeah, you're welcome.
Before you run away, could we, any questions people might feel comfortable asking?
Questions.
Dr. Mickelson will not be available in the afternoon, so
get it.
So get it in now.
Get me while she's off. Yeah. Oh.
We'll repeat the question for you.
Okay, so there's different aspects of neuromodulation. So the question is, how do we access neuromodulation for our patients? So the first statement is neuromodulation is broad, and there's different types of neuromodulation. There's what's called sacral neuromodulation, which is not something we do in BC, but there is also posterior tibial nerve stimulation, which is what I chatted about. If you were interested in having your patient have posterior tibial nerve stimulation, or if one of you were interested in that, it's available through the Bladder Care Centre, and you would need to see a urologist first to be assessed to be appropriate for that or not, but that it is available there. And right now, I think that's the only place provincially that it is available. Any other questions? Yeah.
Sure, this is for Dr. Bolsey, but I'm just wondering about in NMO patients when they have lesions on their spine. Does that usually foreshadow bowel bladder problems? Is there any relation at all to that?
Potentially. Isn't that the answer?
That would be the answer.
Yeah. So, I mean, and this is why there's such a spectrum, and it's impossible for me to say, oh, you have MS, you will have this problem with your bladder, because it just doesn't match any specific pattern.
It's a risk, but not a guarantee.
Yeah.
Is there any evidence for preventative measures to use vitamin C or oregano as well?
All that data on essentially like nutraceuticals in urology is really not clear. And cranberry is technically included in that list, but the best data so far is on cranberry. And what cranberry has in it is an active ingredient called proanthocyanidins that's specifically preventative for infection. People have asked me about vitamin C and oil of oregano. Again, we don't yet have defined evidence-based data for those things yet that I'm aware of.
How often should somebody follow up with a urologist?
That's a great question. So we see patients in various frequency. So usually you have your initial visit, and then depending on what's happening with your disease process will depend on how often you see me. I see some MS patients once a year, once every 2 years, depending on if their symptoms are quite stable. And I see other patients almost every 4 months. And also some of that is dependent on if they're getting Botox injections and that sort of thing, if their care is a bit more active. Yes?
Do these problems increase the risk of kidney stones? Do some of these, like cranberry juice, help?
That's a great question. So the question was, do these problems increase your risk of kidney stones? What increases the risk of stones in general in the urinary tract, either in the bladder or the kidney, is that stasis I was talking about, the fact that the urine is not flowing freely out of the bladder. So yes, the risk can be increased, and that's part of the reason part of the workup is an ultrasound of your kidneys and bladder to see if you're forming stones. Again, if you go on the Metrovan Urology site, there's a whole section on kidney stones. And really what you want to do is look at stone prevention. The most critical thing for stone prevention is water, probably about 2 liters a day. And that, in a nutshell, is also helpful for infection prevention too.
Well, thank you again so much for making time and visiting us today.
Yeah.
Thank you. We're going to carry on with this thing that it really is a multidisciplinary team that's involved. And we're so fortunate in Vancouver to have so many great experts and compassionate experts. And without further ado, we have Dr. Rajiv Ribai, who some of you know already. He's a physiatrist or rehabilitation medicine specialist. And some people say, why are you sending me to a physiotherapist? I'm not sending you to a physiotherapist. A physiatrist is a medical doctor that works closely with physiotherapists, but also works with medications to help manage things such as pain and spasticity, which unfortunately are big concerns and problems in NMO. So without further ado, Dr. Ribai, thank you for joining us today.
So Thank you for inviting me. And Michelle told me to stay in front of the mic. I have a tendency to walk around. As a physiatrist, I like function, I like motion, and like movement of the body, and to keep ourselves healthy. So, Tony, one of the biggest jokes for me is that when I started my career as a physiatrist about 10 years ago, the first consult was for a patient with psychiatric condition because they thought I was a psychiatrist. So a physiatrist is an expert in muscles and nerves and looking at the holistic approach of a patient. And today I'm talking about a very, very difficult subject, pain. And I have 15 minutes to do this. And I'm going to give some key bullet points about understanding the physiology and pathophysiology of pain. Because if you understand a bit about the pain mechanism, we can better understand our pain and also better control our pain symptoms. So today I'll be talking about NMO. Why is it so interesting in NMO? Is because it's very different than MS. Pain in NMO is a different entity in itself, so we'll talk about that. I want to talk about the challenges of treating chronic pain and also giving you some practical approaches for pain management. So when we look at the definition of pain, the International Association of Pain has put this definition that it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, we have two different types of pain patterns: neuropathic, which is nerve-related. It can occur in the central nervous system, the brain, the spinal cord, or outside the central system, the peripheral nerve system, or nociceptive, which is tissue damage. But now we found that with research, they're all married together. It's very much interrelated. So when we look at this little cartoon, you can see that if you stub your toe, for example, you have some fibers that bring up the sensation of pain. We have different types of fibers called A beta fibers, C fibers, D fibers. There are good fibers and bad fibers. They're all kind of mechanically interrelated to modulate the pain. So what happens in this diagram, for example, this guy stubs his toe, the pain process goes up to the spinal cord, it crosses the spinal cord, goes up to the brain, and within that approach, in the brainstem and the thalamus and the cortex, which is the brain itself, the pain gets modulated. So why do we have pain? It's a warning sign. So when the pain system works, we can actually regulate the pain so that we actually can get less pain and it doesn't, linger on. So if the mechanism works, there's a check system at the spinal cord and the brain level, and I'll show you how that works. So if you have pain at the spinal cord, when the message comes into the dorsal horn, the back of the spinal cord, the pain fibers come there, and then the good pain fibers say, I'm going to dampen down the pain. So as you can see, for more pain, you have substance P, glutamate, serotonin, nerve growth factor, CCK. These are bad neurotransmitters. So in order to dampen down the bad fibers, the body starts developing mechanisms from the brain to bring down the bad fibers. So the red arrow you can see, the body starts producing more norepinephrine, serotonin, dopamine, opioids, GABA, cannabinoids, adenosine. These are the chemicals, neurotransmitters, to dampen down the pain. So in a good system, everything's in check, and the pain should not last more than 3 months. Now, as I told you, there are different types of pain. Centralized pain, which is what we see in NMO, because it's affecting the brain and the spinal cord. But we can also have peripheral nociceptive and peripheral neuropathic. We can't always blame pain on NMO. We could burn our toes, that's not NMO, but the processing could actually be different because of the NMO. So we have a complete marriage between peripheral nociceptive, peripheral neuropathic, and central pain. So it's very complex. So when we look at pain in NMO, I like to divide it into acute and chronic. The International Association of Pain divides acute as being any condition less than 3 months duration, and chronic more than 3 months. The reason that's important is because about pain processing, after the 3-month mark, and some people can argue even before, the body starts to be neuroplastic. We have different pain fibers that are more upregulated. The bad fibers take over from the good pain fibers. So when we go into the chronic pain, the pain lasts longer and more difficult to treat. So types of pain, transverse myelitis, you can actually present with pain as your first attack. And that we've seen in research that can be the case. Optic neuritis, for example, in less than 3 months. Now, chronically, we can have nerve pain that can be in a band, for example, where the lesion is in the spinal cord. It could be the point where your leg is so burning and pain that even touching your leg or putting a sock on is really, really painful. And it's really, really debilitating even for putting your clothing on. You can also have spasticity, tightness of your muscles that can affect your walking, the ability that you function putting your clothing on. And that can also be painful because that can lead to contractures, joints being stuck. So it's a very complex entity with NMO. But you can also have visceral. Some of my patients have abdominal-like pain, which can't be explained. And some pain is so unique that you do never have the same person who has the same pain. And that's what I'm going to talk about. The word that I want you to take home is uniqueness of pain. It's almost like I always say my practice when I train my residents and fellows is that it's almost like a boutique hotel. When you come to see a pain doctor or the clinic here, it's individualized treatment. There's not a cookie-cutter way to treat pain. So some of the messages I want to give you as bullet points. Your pain is real. We cannot dismiss a patient when they come to our clinic and say that I'm in pain. They could look perfect, but they're in pain. And that traumatizes families sometimes when they see someone who looks so good, but they're in pain. Or the opposite is if someone's in a wheelchair, they assume that they're in pain. You could still have no pain and be in a wheelchair. So sometimes, the way the appearance is, sometimes we actually put too much emphasis on that when we do pain control. So anytime a patient comes to my clinic, I believe them because pain is subjective. They're feeling that, and I'm not feeling that. They have to educate me about the pain. That's a very important process when we teach our patients about pain, but also teach our residents about pain. You have to live with an element of pain. After 3 months, it's very difficult for the pain to disappear. So you may have to live with it. But the mainstay of treatment is not to allow the pain to control your life. So that's kind of the art of pain medicine, is how can we actually have a buffer to control the pain so that it doesn't control your life. My analogy is like a seesaw. So if you have 50% pain, 50% you feel okay, 50% pain, all you require is a bad day to tip you over. But if you can build a buffer of 60-40, where you can feel 60% better and 40% is a pain, we have that margin of error when you have a bad day. So if anyone tells you they can cure your pain with a magic wand, be careful. Save that money and go to Hawaii. So, I always tell my patients that. But I also have to understand that patients have a right. So there are many things that are not evidence-based, but if they make you feel good and does not do harm, we have to listen to the patient as well. So that's a balance that we have. Now today I want to talk about the conservative and pharmacologic treatments because we may need a combination of both, not just conservative. And again, uniqueness of the patient. Now let's look at the epidemiology of pain in NMO. It's fascinating when you look at the research that pain is more common in NMO patients than MS patients. And some of these studies have shown 86% to 40% in a cohort of about 100 patients. 51% of NMO patients versus 10% of MS patients have severe pain, described of intensity of 7 out of 10, 10 being the worst pain ever. And there's more disability in NMO pain than MS in terms of work, losing time from work, family dynamics, and also having a daily pain pattern affecting quality of life. And also, it could be an initial sign of a transverse myelitis or an attack. Now, why could this be? Well, it's because we actually have long tract signs, so it affects a long segment of the spinal cord, and we also know it can also affect the brain. But the long intraspinal lesion may be one of the reasons. But the other reason is that when we look at MRI and functional MRI for pain, that it actually hits the gray matter compared to MS, which is more white matter disease. And the reason that's important, the modulation of pain occurs at the gray matter of the spinal cord and the brain. And I'll show you how that works. But more than 80% of the lesions in MS is actually in more the white matter compared to the gray matter. And in NMO is primarily in the gray matter. So when we look at this MRI, you can see this, the white hyperdense lesion. That's a long tract sign for NMO. And because it's so affecting the spinal cord, you can have more pain patterns. Also lead to more spasticity as well, which is one of the things that can contribute to more pain. Now, the central gray matter is involved in inhibition of pain input. So the more gray matter you lose, or more that it's actually taken over by a lesion, the less the spinal cord and the brain can dampen down the pain fibers. So when you look at this diagram again, if things are in check, the spinal cord and the brain will modulate down, meaning if a bad pain fiber goes down, we have a mechanism to dampen it down. The dampening down happens in the gray matter, and NMO primarily hits the gray matter for pain. Now, this cartoon, you may see the little yellowish areas, but those yellowish areas are actually the areas that process pain, and that really correlates to the areas that NMO also affects. So that's the reason why the processing is more difficult to regulate the pain than patients with MS, because of the lesions being in these areas that affect the ascending fibers for pain modulation and the descending fibers. Now, this is a complicated slide, but I want to tell you, why is it that even after 5-10 years of maybe even the lesion reducing in size, or you have a little motor vehicle accident, I have many patients like with MS or NMO, and the pain keeps on going on for many, many years. There's a process called central sensitization. So at the back of the spinal cord that I showed you, the dorsal horn, there's something interesting happening, that there's neuroplasticity. The bad pain fibers take over, they get wound up, they get really hyperexcitable. And that can explain that even if a lesion disappears, you can still have a lot of pain, is because of that memory, but that bad memory and the bad C fibers, we call it, the wide dynamic range neurons, sprouting and actually taking over from the good fibers. I just want to stop here, but does that make sense to you guys? Because it's a very important concept, and I always educate my patients, because if you understand what's happening, you can understand why maybe the pain is not going away. Because things can actually sprout to the point that you may have had pain in your back, but now you start developing pain in your leg. That could be related to the actual neuroplasticity of the pain fibers. Now, we also have to rule out other lesions, and that can also be contributing to new areas of pain. So my analogy for that whole concept of the pathophysiology is very simple. NMO has made your fibers more hyperactive, and the wiring between your brain and spinal cord has been affected, making the bad pain fibers more active and making your pain feel worse. So if you have a sunburn, that sunburn may last more than before when you didn't have the lesion. It could keep on going for 3-4 months. All the sunburn has disappeared. That's a concept of central sensitization, that things can actually linger on more because of this hyper regulation of the pain fibers, and the dampened modulation because the NMO affecting the gray zone or gray matter of the spinal cord and brain. So pain in NMO, your pain is real. I want every one of you to realize that. You're not making it up. Number 2 is, today, how many of you have experienced pain? Can you put your hands up? So there are a few that haven't experienced pain, which is great. But the majority of us have experienced pain in many different ways. Emotional pain is also pain. Psychological anxiety, that can be indirectly related and amplify your pain. Now, pain processing is variable. And we have also seen in research that genetic influences are different. Everyone in this room is unique. And in the future, we'll be having, I think, ability to know your phenotype, meaning that this is a way to treat Ms. Smith compared to Ms. Jones, because genetically they're more predisposed for this medication to work better at the level of the dorsal horn or at the spinal cord. I think in the future that would be very interesting to deliver the medication as a unique phenotype of the patient. So looking at the individual person, even at the genetic level. Again, pain is unique. And I want to show you this patient of mine. I asked this patient, I said, can you describe the pain? And he's an artist. And he said, Dr. Ribai, I can't tell you what I feel because you won't understand. So he came to clinic and he drew this. Now, I don't know if you can see this painting, but it's beautiful. He's not a medically trained person. He's an artist. But he wanted to show me his uniqueness of the pain. What I really love with this painting, you can see what I've been describing, the central sensitization, the flare of the nerves. You see these neurons on the head, in his head. The red, which is the allodynia, even touching him, he would actually jump up with pain. The blue, the cold sensation, the intolerance to cold. This is a description of pain. And this uniqueness for me is very special. And he actually termed this, without me telling him, neuroplasticity. So it's interesting how sometimes your body knows what you feel, and if you want to describe it to your physician with art or in other ways, do it, because we can get a better understanding. Because of this painting, I was able to treat him better because I knew that he had cold and hot changes. He also had a lot of nerve pain patterns that was affecting his life, and also to touch. So we use a topical cream of an anesthetic to dampen his pain down, and we use gabapentin, which is a modulator to bring down the bad pain fibers. So an example of the uniqueness of pain. So what is a treatment plan? Now, I can spend hours talking about this, but I want to make it very simple. I believe in patient-centered rather than disease-centered. So we have to look at what the patient needs. Patient autonomy. Sometimes patients don't want to listen to what I tell them, and they want to tell me what they think is right. I have to listen to that, but I have to balance the risks and benefits of what they want. I like the individualized treatment plan and goal focus. Very important that I have the same goals as a patient, that we are actually on the same page when we're doing the treatment. So the basics of pain treatment, it has to be involving improvement of quality of life, and that's very important. Now, this is kind of how my brain works, so you don't have to read everything there, but it's very complicated to deal with pain. You start off with a history. You have to understand the pain. I love a pain diagram so the patients can tell me where the pain is. But we look at conservative measures. Sometimes I have patients walking into my clinic. The cane height is wrong. They're walking like this, and they've been sent to me because they have back pain. Well, the simple thing is to actually get the cane at the right height. These are simple strategies to actually look at the patient holistically first. Then we zone in onto the actual treatment. We can base this on my colleagues, like Dr. Trabolsi will tell me, well, this person has had a rituximab, he's having a lot of nerve pain, he has a lesion around T10, he's got band-like sensation, so I can target that treatment to look at neuromodulators, where I can look at medication to dampen down the pain, and medications such as gabapentin, for example, Cymbalta, duloxetine, they increase serotonin. Serotonin is a good chemical to dampen down the pain. Cannabinoids, that's a new thing that's coming in our field, and I find this now it's knowing which strain, the CBD or THC, to know what can dampen the pain at the spinal cord level. Then you can see a lot of things about exercise, and we also have desensitization, cognitive behavioral therapy, for example, from psychology, massage therapy, and TENS machine, and I'll talk a bit about that. Medical, you can see pulse steroids, we do that for an attack. And the game changer also, I've seen mitoxantrone and rituximab, because I'm seeing more and more the early detection, the less pain patterns that a patient can have. So this is just a big, my brain in one slide. This is a very important slide. If you want some resources, I really would advise you to use these resources. It's free. The top one is the Pain BC Toolkit. It's actually a government-mandated program. They have a lot of self-education programs on there. There's a website, www.pain.bc, and I really would urge all of you to connect with them. They're really there for us, for patient advocacy, and also we can make them more aware of NMO, because we can also have more funding, and they can also help you with disability funding as well, if you're finding that things are difficult with your chronic pain. Because with disability forms, as you may know, they sometimes do not believe that the pain is real affecting your life, so we have to help you in filling out these forms correctly, and they can. St. Paul's Pain Clinic, Jim Patterson Pain Clinic, these are our government-mandated pain clinics. And then Change Pain Clinic, which is in Vancouver, is also a very good resource. It's MSP-driven with some private pay-for pain control. And I just want to move on just a few things. These are the conservative management that I think we should never forget. This is very, very important. I really am a believer in Tai Chi yoga. These things can really help, and there's evidence that Tai Chi, believe it or not, the movement, you can do it in a wheelchair or able-bodied standing. It can actually bring up your heart rate. It can actually bring down cardiovascular risk if done properly. So these are things that are very novel, that has no impact on the joint, that we can try. Stretching, massage also has evidence, level 2, to help dampen some of the pain fibers, especially for soft tissue pain. And acupuncture as well, and hot and cold, depending on what you can tolerate, can help as well. And water therapy, I'm also a big fan of that. Now, when we look at NMO, fatigue is a main issue. So we have to get a program that can actually help you, so we can see what do you like to do. I've got many couch potatoes amongst my patients, and many of my colleagues are also couch potatoes. So I have to, get them more active. So you can't expect someone to do the marathon if they've never even run in their life. So you do what they want. Now, walking poles. Now, a lot of people hate the fact that I'm going to tell them to use poles or gait aids, but sometimes for exercise, it's really good. You can use a walking pole if your balance is off to increase your endurance and increase your ability to walk longer distances. Even a walker, for example, can help you stabilize yourself, if you have balance issues, but you can use that as a tool for exercise. Benefits of exercise, it's not only decreasing pain, but decreasing hypertension, improving your cholesterol profile, muscle strength improvement, weight reduction, and overall all to increase your quality of life and your survival rate. There are some studies showing that if you are exercising at least 15, 20 minutes per day, these are studies with walking, you can increase your life and quality of life by 2 years, which is a big statement, but that's an amazing thought. Types of exercise, if you can walk 20 minutes daily, doesn't have to be all in one, but the studies have shown if you can cut it into 5-minute intervals 4 times a day, that'd be great. You know, that's going to be good for your overall well-being. If you can't walk, you can do movement in your chair, Tai Chi, yoga, for example, or using a ergonometer, which is like a bicycle for the hand. That can be a really good tool for management of your pain. Water walking, wheelchair in the water as well. We have many pools accessible, and aquascience therapy. Simple exercises, those are called isometric. There's no joint movement to build up muscles, and our physiotherapists can teach you that. TheraBand exercises to help overall stretching and also distraction. For example, this lady has back pain, so what we've done is by stretching, you can actually strengthen the low back, but her brain is thinking she's working with the biceps. So this is a very nice engagement or activating exercise. This is a very nice website, and this is on you're going to have access to this, but this is an MS program from the UK, but a very nice program for exercise for home and for therapy for individualized patients in wheelchair or also ambulators. Tai Chi, GF Strong, we have an adaptive Tai Chi program, which I find is an amazing program. Stretching, if you can spend 2 minutes a day, please stretch, slowly stretch upper and lower limb to stop having increased tightness, which can increase pain from spasticity. And adaptive yoga, which is great. And water-based exercise, I think this is amazing. We should all have access to a pool. We have George Pearson Pool in Vancouver. It's a bit too warm for my patient with MS and NMO, 33 degrees, warmest pool in Vancouver. But if you do like the water, you know, if you can get something like that. And a water belt is good to have more ability to run, even in the pool. And if you can't run or walk in the pool, you can use a wheelchair adapted for the pool. And if you're really, really, you know, keen, you can go to the Paralympics, you know, and get the movement with exercise. A lot of community programs for wheelchair curling, for example, at the amateur level to the elite level. Wheelchair rugby. I don't know if you've ever seen that, but there's a lot of things you can do. So even if your mobility declines and your pain declines, these are great activities for distraction for pain. So I just wanted to say, I wanted to talk to you about the uniqueness of pain. It's no patient with NMO is the same. I really believe in the multidisciplinary team approach and about rational polypharmacy. It's not only about medication, but the whole goal for pain management is quality of life improvement. Thank you. So any questions before I get kicked off the stage? Yeah. Yes?
I was trying to elaborate on water therapy.
Yeah. So it depends. It's another talk on its own, but water is a very nice modality to distract the pain fibers. So it desensitizes your body, but it also allows you for aerobic conditioning. So if you're able to walk, even walking in the pool, 5-10 minutes once a week, in the width of the pool, up to the neck depth, and then slowly bring down the water. That is a good way to build resistance training as well, and also cardiovascular ability. Some of my patients, even the vibration on the ground can actually increase their pain, so getting them in the pool can activate them. And for those who really want to push further, you can get a water belt and start treading water in the deeper end, and that can train you for increasing your VO2 max, your cardiovascular output for your overall health.
So it's not like using cold temperature water?
Sure. Yeah, so there's also the theory of desensitization from cold to hot, yes. The problem is to find the right temperature for our patient. That's a big problem. Yeah. Yes? Yeah.
In terms of if you have a referral to a pain specialist,
Yeah.
is it like what is the difference between what you're doing and what a pain specialist does, and which is better for an NMO patient?
Which is better for us to see you. We have very few of us. That's the problem. I'm happy to see all of you, but it's more of a capacity issue. But the pain clinics work very closely with us, so we can always share the care, which is a great thing. So I've always told Dr. Trabulsi, I think every NMO patient should have a physiatrist. Okay. All right. Thank you.
Thank you very much. Dr. Reba is a typical Canadian, very humble. He was the one that initiated a more closer relationship between physiatry and MS and NMO over the past over 5 years. And it's just been enormous benefit to our clinics and our patient community. So I want to personally thank you for that initiative. That came from me directly, and I'm very grateful for that. Thank you. So without further ado, very fortunate to have Claire Sheldon join us today. Claire is a neurologist who did extra training in neuro-ophthalmology and is a neuro-ophthalmologist, has that specialization in the optic nerve, and she's going to share her experience with us today. So thank you, Claire.
Thank you.
Oh, you've got your slides up already.
Okay, thanks.
And please talk to the microphone and the audience.
I will stand closely. All right. Well, thank you very much. I'm really pleased to be here today. It's lovely to see so many people. So as Dr. Trabulsi mentioned, I'm a neuro-ophthalmologist, and today I'll be talking about NMO and the eye. And you may be wondering, what is neuro-ophthalmology? And I'm just going to start with that. I'm an ophthalmologist, but I obtained specific training in neuro-ophthalmology. That's the specialty of neurology or ophthalmology that deals with visual symptoms caused by changes in the optic nerve or the brain. It also deals with changes in the vision that may be related to incoordination of the eyes or abnormal eye movements. And as a neuro-ophthalmologist, my job is to evaluate, investigate, diagnose, and help treat individuals who present with some of those symptoms. And at the UBC MS and NMO clinic, there are in fact 3 neuro-ophthalmologists there, available 3 days a week, to see individuals who have any sort of visual symptoms. And again, my job is to identify what's going on, is it related to MS and MS and NMO, and what can we do? And so the outline of today is actually a bit of an introduction to the eye. I really want to demystify the eye, demystify what we do in the neuro-ophthalmologic examination, and then bring it back to a case presentation to talk a little bit about treatments and future thoughts and ideas. Okay? So the first image here, we'll go through the introduction of the eye. This is just your regular external image of the eye. We can see our external features here, the eyelids and the lashes, and the colored part is the iris. Here's the conjunctiva and the sclera. I'll also point out the pupil because I'm going to talk about that quite a bit. The pupil is this black part right here. And if we then remove the eyelids and turn the eyeball on its side, this is what we get. Okay, we're all learning our eye anatomy here today. And we can still see the sclera, which is the white part. We can still see the iris, which is the blue part in this picture. But we appreciate now that the iris is actually inside the eye. Covering the iris is a little clear plate, and that's called the cornea, which is like the windshield of the eye. We can also see that that pupil that I pointed out before is not actually a black structure. It's actually an opening of the iris. And as neuro-ophthalmologists, we spend a lot of time looking at that pupil because it tells us a lot of clues about whether your visual symptoms are related to the optic nerve or not. And then that pupil actually controls how much light gets into the back of the eye, and that's all in here. And so the back of the eye has the retina, which is this beautiful orange structure. And here's an image of the optic nerve, which is the cable that connects the eyeball to the brain. Here's another image of what we've just gone through. So there's the external picture of the eye. And then if we look at the eye sort of from front to back here, there's the cornea, the pupil, the retina, and that optic nerve that's beginning its travels to the back of the brain. Now, I mentioned to you a little bit about eye movements. On top of this structure of the eyeball, there are attached to it on each side 7 muscles that control the eye movements as well as the eyelids. So when we do all of our fancy eye movement tests, is because I need to know if one of those muscles are not working, and if so, which one is it? Because that'll help us identify the cause of any symptoms. You can also see peeking out behind these muscles that are attached to the globe, this optic nerve here. So again, traveling back into the brain. Our next image is an MRI image, which many of you may or may not have seen, but I'm just going to orient you a little bit because it shows us really nicely some of the anatomy that I'm thinking about as a neuro-ophthalmologist. This is the right side, this is the left side, this is the front, and this is the back. These two are the globes, those are the eyeballs, and we can see this tiny structure here, there, and there. That's the optic nerve. That's what I think about a lot. On the side here, those are 2 of the eye muscles that move the eye. We can also see this structure here, which is part of the brain stem, and it actually houses many, many nuclei, many, many nerves that then feed forward and control those muscles that move the eye. Okay, so we've actually gone through all of the anatomy to be a neuro-ophthalmologist. So the next one is what we're going to know with that information about the anatomy of the eye. How can NMO affect the vision? Why is a neuro-ophthalmologist important in this condition? Well, as Dr. Trabolsi outlined, that NMO is a condition of autoimmunity or inflammation that involves specific structures within the brain. We've already talked about some of those structures. NMO and NMO spectrum disorder has a tendency to involve the optic nerve, and when it does that, it causes vision loss. That is called optic neuritis. NMO can also affect areas of the brainstem. Remember, we talked about those areas that have nerves that control our eye movements. So if NMO is affecting those structures, we can have symptoms like double vision. And I'm going to go through, in our next slide here, we list some of the symptoms that when people come to me and they say, I'm having some problems with my vision, I say, great, well, I like Dr. Rebai's discussion about the uniqueness. You really need to listen. What are you noticing in your vision? You're not going to come in and say, I have optic neuritis. You're going to say, maybe I'm having some blurry vision. Okay? So I'm going to be listening for changes in vision. Is it progressive? Is it changing over time? Is there associated eye pain? That may twig things like optic neuritis. Double vision and shaky vision, that's less optic neuritis and more likely potentially related to inflammation within the brainstem involving the nerves that control our eye movements. So I'm listening to symptoms that make me think about that. What's important when we think about optic neuritis in NMO, it's actually quite a common presenting symptom in individuals who have NMO, approximately 50%. And a reasonable number of those 20% patients, it actually may be bilateral. The unfortunate situation here is when NMO affects the optic nerves, in contrast to MS affecting the optic nerves, the vision loss can be quite profound, quite significant. And so we really need to characterize and get on top of that as quickly as we can. Individuals, even if they don't present with optic neuritis, may and still have a risk of developing optic neuritis during the course of the condition. So again, seeing a neuro-ophthalmologist, seeing an ophthalmologist is important and very important if you're noticing any changes in your symptoms. So the next couple of slides are what I think are really important slides, because when I sit down with somebody who's having visual symptoms, this is what I'm going to ask. I'm going to listen very carefully to the symptom, and if we sort of going down the road of blurry vision, changes in vision, what I'd like to know, or what we'd like to know, is do we think it's involving the right eye, the left eye, or both? So just simply, as a patient, if I'm noticing challenges with my vision, look at something like the television, cover one eye, cover the other eye, both eyes open. Okay, it sounds so simple, but it really is the first question I ask. One eye, other eye, or both. I'd also like to know, is it blurry all over, or all there areas or there patches of blurriness? And this photo down here is meant to simulate what an individual sees with optic neuritis. And you can see that there's a sort of a thumbprint or a smudge in the vision here, and that's blurriness. You can also see that in this lower picture, the colors are remarkably different than this more typical normal representation. So the colors are washed out, maybe dimmer. And that's something that, as a neuro-ophthalmologist, I listen to, and that suggests possible optic nerve involvement when color is a concern. I also want to know, are the changes in vision different, near or far? How did the symptoms start? Have there been changes over time? Okay, so we really want to have a good characterization of some of the symptoms. If we're thinking about something like double vision, many of the questions are quite similar, but again, covering one eye, covering the other eye is critical. If you have double vision when you cover one eye, it is rarely, and I hesitate to say never, because nothing is never. It's really never related to the brain. Okay, so that's really kind of reassuring. But so I need to know if the double vision is there when you cover one eye, the other eye, or both. Are the two images side by side or up and down? That'll help me identify the nerve or muscle that may be involved here. Is it worse in any particular direction of gaze? And how did the symptoms start, and are they changing? It seems silly to go through these two slides, but truthfully, I think this is a really good way at home, if you're noticing changes, to kind of go down the list and say, are these changing over time? Is it one eye? Is it both eye? And next, what we're going to go through is the eye examination. What do neuro-ophthalmologists do? How do we characterize and tease apart some of the symptoms that we've just tried to characterize? So first, we measure your vision. What is the level, the lowest row that you're able to see in the chart at the end of the examining room? We'll check one eye at a time. We may use some lenses and other tricks to kind of optimize the vision as much as possible. We'll also check your side vision, because central vision may not be where the area of problem lies. So we check your side vision just by confrontation, as shown here in these pictures. We check your color vision, and a lot of individuals, a lot of patients say, well, doc, I'm not colorblind. I say, well, I'm not using it for colorblind. I'm actually using it as a clue, because if optic neuritis is contributing to some of changes in the vision, color vision is one of the features that's quite prominent. So those color plate books that we pull out on each test, that again is looking for optic nerve function. Similarly to optic nerve function is that pupil that I talked about right at the very beginning. This is a really important clue that, again, I'm staring at, shining light in one eye, then in the other eye, looking at how quickly the pupils respond, the reactivity and the size of the pupils. Really important. A clue for optic nerve problem, whether it's contributing to any changes in vision. I'll also carefully look at your eye movement, so follow my finger, left, right, up and down. I'm looking to see how well your eyes move and whether there's any extra jiggliness or shakiness called nystagmus of the eyes. One of the additional tests may be having patient look right at the end of the room, and then I cover one eye and then the other eye, and that's not so much for vision, but I'm checking to see whether your eyes are well aligned. a subtle clue of looking your eye movements, okay? Then we've gone through sort of your measuring your vision and looking at your eye movements. Then we turn to the slit lamp, which truthfully is just a big microscope for me to look at the eyeball. And I look at all of those structures that we talked about at the beginning, the cornea, the iris, the sclera, the eyelids, because when individuals come to see me, we can't, as a neuro-ophthalmologist, just jump and say, well, your visual symptoms must be related to NMO. We have to have a look at everything as a whole. So we have a look at the eyeball with the slit lamp. And then when I look at the back of the eye, this is the kind of thing that I see. And absolutely, this is an absolutely beautiful optic nerve here. This is the right eye, this is the left eye, and the orange sort of structures with the vessel, that's the retina. Okay, so the retina and the optic nerve. You can see that when I'm looking at the optic nerve, I can't see the rest of the cable as it extends into the brain. I can only see the optic nerve as it's facing me. So this is a closer picture of the optic nerve here. There we go. And so this is the margin of the optic nerve, and I'm looking at the color in between the blood vessels. This is nice and pink, and the same thing here. This is the left side, and I'm looking for any swelling, any paleness, which I'll talk about later. These ones look quite healthy. So with that sort of examination in mind, then I need to decide, is there any vision loss? Is there any optic neuritis? Are the eyes moving well? Is it related to NMO and NMO spectrum disorder? Some of the things that we may end up doing is additional ancillary testing is visual field testing, which is kind of an unpleasant test because it's not very much fun to do, but it's very helpful in our area of neuro-ophthalmology. This is an automated visual field test, and this is the larger Goldman visual field test. Many of you may have gone to the eye care center, either at Vancouver General Hospital or St. Paul's Hospital, to complete these tests. And basically, when individuals are sitting in here, their chin is resting on the chin rest there and there. They're looking right at the end of the bowl there and there, and they're pressing a button or tapping on the table when you see the lights flashing around you. And that provides me a map of your peripheral field. That provides a lot of information. If I'm not sure what's causing the changes in vision, that map will help me figure out whether it's the optic nerve, whether there's another area of the brain to be concerned about, or if the visual fields are normal. That's really reassuring. The optic nerve is functioning well in those situations. This is one result of a visual field test. I know when I see patients, I like to show them their visual field. This is the visual field of a right eye. This is the left eye, normal on the right. On the left, this tells me that up above on the left, this individual has difficulty seeing. This is characteristic of an optic nerve problem. So we've localized it, and I would add that to the rest of the examination. The other types of visual field, the Goldman visual field, are a little bit more extensive. They take about an hour to do, but it's like a topographic map of the visual field. Each line is a size and brightness of light. So this gray one here, that's the big and brightest light. And so this individual can see the biggest, brightest light. This is the left eye on this side, all over here, but it's missing up on the upper right. Can't see that. And then this is the right eye, the map of the visual field of the right eye. Can see that big and brightest light all the way over here. Can't see it up there. This is not optic nerve. This is brain. By the map of the visual field, I can tell that. Okay, so right away we know where to localize things and where to be thinking about further testing. The other additional test many of you may have had is the optical coherence tomography, or OCT. Essentially, it's a laser picture of the optic nerve, and we also use it for the central part of the retina. And a couple of the results are shown here. This is the optic nerve, and we can see that this is the green line. At that green line, the computer measures how thick the retina or the optic nerve fibers are. And in this panel, very nice and normal. So sits within green, which is the normal variation. In this individual, there's a little bit of thinness or pallor in one quadrant. We're going to talk about pallor later on. But this is the OCT, can be quite helpful to quantify the structure of the optic nerve, particularly during the times of visual symptoms, but also changes over time. All right, so we've talked about the eye examination at length and some of the additional testing that may or may not be involved. I'm going to talk about a case that I saw in my fellowship, a really lovely 50-year-old woman who came and she had a for 3 weeks, she was noticing some discomfort, kind of like her left eye was swollen and her vision was becoming progressively worse. And she was really only seeing out of a little central slit in her left eye, but the right eye was normal. Now, when I saw her, she had quite significant vision loss. HM means hand motion, so she couldn't see the letters on the chart projected at the end of the room, but was able to see my hand moving. And I looked carefully at the pupils, and they were not reacting as well as I would expect on the left side. So I knew the optic nerve on the left was involved, and I was quite suspicious of NMO. And so I had a look at the back of the eye, and this is the right eye. And here's the left eye. So the right eye looks actually very normal, nice and pink, no swelling, looks good. The left eye is a little fuzzy. I did my OCT, and yeah, this is the thickness of the optic nerve. It's thicker than what I would expect. So there's some swelling of the optic nerve, which is in keeping with the level of vision loss on that side. And so she actually was treated with a course of IV steroids, so IV methylprednisolone, and then she was followed by oral prednisone by mouth, and this is a generally long taper in the setting of NMO. And so this was her first attack of optic neuritis, which led to a diagnosis of NMO. And we can see that the vision loss is quite profound initially, but in this case, although it is not the case in all situations of optic neuritis and NMO, her vision actually recovered reasonably well to 20/50. The pupil was still a little bit not reacting as well, but that level of vision is much improved. So in terms of management strategies for optic neuritis, different to the previous talks that have kind of been dealing with chronic situations, optic neuritis is a relapse or an attack of NMO, and it requires both an acute treatment, which is generally steroids, and then you can add plasmapheresis, and it also requires other medications in collaboration with the neurologist to prevent relapses, because you want to prevent any more attacks, to prevent any more damage to the optic nerves or the areas of the brain that control the eye movements. If the vision unfortunately does not recover, there are visual supports in the community, which can certainly be explored, and as a neuro-ophthalmologist, I'm definitely a liaison or connection in that regard. Optic atrophy, I just want to touch base on, because there are a number of individuals that we see in clinic where we say the optic nerve looks a bit pale. It really, it means that there was means that there could have been optic neuritis before. It does, and it meant that the optic nerve struggled with something, kind of like a scar. It doesn't necessarily mean that the vision is not recovered well in that eye, but it tells me that the optic nerve struggled at some point. And the optic atrophy, I've shown a picture here. I'm not sure if this one projects as well, but maybe in contrast to the other images, we can see that the sides of the optic nerve are more white compared to the other pictures that we saw earlier in the talk. I get a lot of questions about stem cell therapy, and it's hard. Stem cell therapies in eye conditions are being more and more, they're explored increasingly larger number of conditions. When it's used for the eye, Most often it is for cells that sit in the eye, okay? I haven't gone into the different layers of the retina, but the retina has lots of layers. Some of them just sit in the eye. They communicate with cells in the eye. They're very small, short, square cells. Those ones, that's where they're trying to use stem cell therapies with some success. The optic nerve, as hopefully you appreciate now, is a cable that travels from the eye through, well, starts in the eye, through the optic nerve into the brain. Stem cells are much more challenging in this situation because you have to not only get the cells into the eye, they have to tell it to grow through the optic nerve and connect where it needs to connect to allow to restore vision. It's challenging, but I'm not going to say people aren't trying. People are trying. In fact, there is one study, I could find one study in India where they're actually using some stem cell therapies, but I don't have any information about its success or not. Okay, so I just want to discuss stem cell therapies and talk about some of the challenges or potential utilities of it. So what we've done so far, hopefully you're all experts on the anatomy of the eye. We've talked about NMO and how it may affect the vision. If there are changes in vision, please follow those questions that we talked about. Come and see a neuro-ophthalmologist. We are available at the MS clinic. I've gone through the eye examination, again, to demystify what is the doctor doing during all this time, and then talked about some of the treatments. And if there are any questions, I'd be happy to answer them. Thank you. It's crystal clear, right?
I think sometimes one of the challenges is determining when there's some early eye pain, if that's early optic neuritis or just some eye pain.
Yeah.
And it's nice having neuro-ophthalmology available on short notice to evaluate that.
I think so. That was one of the reasons why I went through the eye exams so carefully, is because it's important for patients, for you, when I'm examining a patient, for you to understand what I'm doing. Because I cannot just say, well, eye pain, it must be NMO. No, eye pain could be dry eyes. It could be angle closure glaucoma. There are lots of, it could be iritis. It needs to be examined properly. And if I cannot find evidence of what the trigger is, but I'm concerned about optic neuritis, that's where those ancillary testing comes into it. The visual field, the OCT, provide additional information. So I can say, you know what, Tony, this is optic neuritis, you need to treat it. Or let's watch it for a little while. I'm going to do another visual field in 2 weeks, 4 weeks, and go from there. So that's one of the reasons I spent so much time going through it.
The previous two speakers had things you could do to improve your bladder, to do more exercise, to relieve pain.
You noticed the lack of that in this talk, right? So carrots, a lot of the nutritional supplements for eye health are actually for the retina. There is limited evidence for any nutritional supplements for optic nerve health. And again, we just don't know what vitamins those retinal ganglion cells need. And there are, so nutritional supplements, there's no evidence for me to say which ones to use. Certainly healthy diet seems quite reasonable. Sometimes individuals come and ask me about exercises for the eyes. I'm having one eye, it's not as strong as I'd like it to be because of a previous episode of optic neuritis. Again, there are some individuals that go through recommending visual rehabilitation movements. The evidence for that is quite limited. I reassure people that you are not doing any damage to the eye by using it. You are not straining the other eye, if that's the good eye and this eye has been affected. You're not damaging that eye by using it. You use your eyes as much as you feel comfortable. come to see us and we'll help you with any glasses that you may need in the distance or at near. But unfortunately, reassurance, I think, is one of the big things that come from us. If I say there's no active optic neuritis and things are stable, they really are. And use your eyes as you feel comfortable.
In general, we recommend people stop smoking if they can. What are your thoughts on the risk of smoke or tobacco and optic nerve?
Absolutely. No, so thank you. Absolutely. Smoking and alcohol are toxins to the optic nerve and how it functions. I don't know if there's evidence in NMO and MS in particular, but certainly other type of optic neuropathies have been shown to worsen with smoking in particular.
Right. Now, I didn't mention alcohol. How much alcohol?
Not excess, everything in moderation.
Okay, but not smoking in moderation.
No.
Okay. So
Smoking is very clearly a zero, and then alcohol in moderation.
Thank you.
And with a good diet.
Not a diet of alcohol, though.
No, yeah.
Above.
Yeah. No, not at all. I mean, no, I really, again, reassurance. If it feels comfortable for your eyes, go ahead and use the digital platform or the paper. Sometimes people may notice some light sensitivity. I'm not convinced that that's specific for the NMO population. I see many patients with light sensitivity, and sometimes tinted glasses are symptomatically helpful. FL41 glasses in particular can sometimes be helpful for light sensitivity, but there's no evidence that, again, you're going to be straining the eyes or worsening it. Yeah, yes, because if you think about it intuitively, there is damage to the optic nerve following an episode of optic neuritis, and if you have 1 million fibers, which you have 1 million cables going along the optic nerve, each episode of optic neuritis will damage an additional one, so harder to recover from. So again, one of the reasons why come and see us if you're noticing any symptoms, and we can help. Yeah. No, well, if you're connected in, as far as I understand, if you're connected in with the UBC MS clinic, you can call the clinic and see the neuro-ophthalmologist there. That's correct?
That's correct. Yeah. So that's the whole idea of it's not perfect, but we try to fast track anybody who's having a relapse. The idea is to call the relapse nurse Monday to Friday, not weekends, because don't have that level of service. And then she will triage and discuss with one of our fellows, bring the person in quickly to the clinic, and we have neuro-ophthalmology access, which is fantastic, 3 days a week. So we can fast track for our patients that are associated with our clinic. Yeah, and we want people to tap into that resource. And I apologize when your calls aren't answered. That's why we have the cards outside. Plan B or C, let's call that guy there, Rob Crothers. I'm Plan E. If you can't reach Rob, call me. But ideally, we'd prefer you go through the pipeline rather than putting all the burden on Rob and I. But we're kind of your last resort. Isn't that scary? But yeah, we're your last resort. So we wanted to make sure there's several levels of so that people don't fall between the cracks. But we recognize it's not perfect. We're trying our best to make it as good as possible with the resources we have. But Claire, thank you so much for all that, and really appreciate it. So again, great. We're hang in there. We're almost there. Again, it's a team effort. We've got two wonderful people with us here today, Sue Farwell and Denise. Sue's the head of occupational therapy, professor at the University of British Columbia, and she and Denise have been developing and enhancing this program of occupational therapy and helping people manage fatigue and energy conservation. They started a program where occupational therapy students are part of the clinic and get exposed to the important issues, so that this is, again, is another generation going out there to support the community. So without further ado, please join us. And please talk into the microphone.
I'm going to actually use this one. I had.
Oh, I'll take that. Change your slides.
I did.
I recommend the key there. I'm standing right about here.
Okay. And this is how you can hear me? Okay. So I'm going to get it all set up down here, and hopefully it'll work. I feel very privileged to be part of this panel of presenters in this NMO Day. I was able to present last year, and as Tony said, we do a lot of things in occupational therapy, and last year I presented specifically on fatigue. Today, I'm going to talk about sort of a bit of a triumvirate of invisible symptoms in NMO, because I've spent a little bit of time looking at the issue and feeling really frustrated about the lack of research. So what I'm going to present today is a little bit different and present you where we are with the state of research in 4 different areas. So the 2 things I want to cover is a bit of a background on 4 invisible symptoms, and then go into a little bit about a preliminary study that we're running here at UBC to sort of uncover some of the story around those symptoms that we really don't know about. So the 4 symptoms that I'm going to talk about are fatigue, depression, anxiety, and pain. I'm not going to go into pain into much detail because Dr. Rebai has done an outstanding job of providing an overview of that. But I want to give a little bit of a lay of the land of where our research is. So first, let's start with fatigue. We know that in NMO, so last year I presented a similar table and I did MS, and then NMO. This year I'm just looking at NMO. And the literature suggests, and there's only 2 studies that have given some kind of incidence data, that between 43 and 58% of people with NMO experience a fatigue that impacts daily life. Where it ranks in terms of their worst or best or least problematic symptom, we don't know. Hopefully we can discover that in some research we're doing. It does have physical, cognitive, and emotional components. The research does show that it impacts daily life, employment, and education, and associated with cognition, depression, and disability, but it's not associated with markers in NMO, MRI abnormalities, and a study showed that it was not related to physical disability. So you see in the line above, it says it is related to disability. The next line says it's not. This is normal. There often is tension in research where people come up with different findings, and therefore that is the need for multiple studies to actually really coalesce around one issue to be clear about what really the impacts are and what the influences might be. So from our experience, we do know from what you tell us in the clinics is that it does affect your valued roles. You may have to stop working, as I said, and the thinking. You lose your patience. You can't think the same. Things are foggy. But things that we don't know about NMO that we do know, say in MS or in arthritis, where fatigue is also an issue, is that the approach, we know that in MS, the approach of just working really hard to just get everything done before the fatigue starts doesn't work. It actually makes it worse. But we don't know if that's the same in NMO. Family and friends are tired of you being tired. And some of you, your family and friends might know that, but it's not in the literature. And when it's not in the literature, we're not developing appropriate interventions to be able to identify. We've got to provide support for the families and caregivers because the fatigue is real. The fatigue may affect sex life. That has not been determined in NMO, and where it is ranked in terms of the volume of the symptom. So I want to move on to mood, and what does the research in NMO and mood talk about? Now, there's some general things in mood that the research talks about. 2 studies identified that between 25 and 27% experience depression. And another study suggested that it was actually 58%. And another study said 67%. Well, now that's a pretty wide band, 25 to 67%, isn't it? I think we need to get much better data to really understand how mood is operationalizing itself in NMO. We don't know where it's ranked in terms of symptom magnitude, but that it does affect quality of life and work. And this is similar to many conditions. We don't know what factors contributed. The literature has not identified that. It is not associated to physical disability. Again, there's a tension in the literature because one study said it was and another study said it wasn't. But it is associated with poor cognition. So now we're starting to see the link between at least some of these things, that these cross symptoms. I'd like to go to anxiety. There's very, very little research on anxiety. At least in fatigue, we might have 10 papers. In depression, we might have 10 papers. In anxiety, we have 2 papers in NMO that show roughly 68% have anxiety. If that is the true number, anxiety actually seems to be more of a problem in NMO than depression. So that's an interesting observation if this literature does bear itself out in multiple studies. Again, we don't know where it's ranked in terms of the magnitude or the importance. Negatively affects quality of life, disability, and fatigue and depression. And it is associated with a shorter disease duration, meaning that if you have a large magnitude of disease early on, you'll have larger anxiety. I want to move to pain, and again, I'm not going to spend much time on pain, but just give you a little bit of data of what the literature is telling us about the pain experience in NMO. I think we all feel pretty comfortable that the pain piece of the invisible symptoms is probably the most weighty piece in NMO. And certainly a number of the studies have shown that it's upwards to 85, 86%. And I think we can start feeling comfortable with that data because it's been repeated now across 4 studies. One study showed 57%. But I think the point here is that pain really is a very significant symptom. The types of pain that are described have already been described by Dr. Rebai. It does contribute to a lack of quality of life, and it impacts ability to maintain work. It has been shown not to be associated with age, sex, MS duration, or MRI metrics. So what this little skate over or overview of this research across these 4 invisible symptoms is, one, that there's very limited research in these 4 entities across in NMO, and that there are many unanswered questions. And without questions being answered, it's really hard to develop appropriate assessment tools for NMO, which could be slightly different than having these same things occur in MS and spinal cord injury, for example. So I've been creating assessments across different entities, and what I've learned is that to say that the fatigue in stroke or TBI or MS or NMO is the same, it's not. What we are learning as we characterize and we drill down, the experience is slightly different, but also how it manifests itself. In MS, we know that it predominantly occurs, the abnormal fatigue predominantly occurs in the early afternoon, late morning, early afternoon. But we also know that if you have fatigue first thing in the morning when you wake up, may not be MS fatigue, it may be related to poor sleep. NMO may have the same kind of breakdown, and that's what we're looking for. We need to understand what that picture actually looks like, how it presents, before we can come up with effective assessment and intervention strategies. Right now, we use very general strategies to support the treatment of these issues, which is a very good start, but let's look at trying to get something more targeted. So with that, I want to go to the second point in my outline, which is to look at some preliminary results in a small study, cohort study that we're doing here at UBC, related to fatigue, depression, anxiety, and pain. Right now, there is no data in the literature from British Columbia in NMO along these four entities, and we hope to change that over the next 6 months with your help. So the study began with the purpose to describe fatigue, pain, mood, and anxiety, and its impact on your daily life for those of you that are living with NMO. And so the approach that we've taken is a questionnaire-based, a very simple study, where with the support of the UBC NMO database that Tony has set up and his team, I met with them in the summer, and we looked at how we might operationalize such a study. And I will go into that study. I'm going to give you a few preliminary results, but we also have, if you'd like to be involved in the study, we can talk about that also. We've just sent out these questionnaires to those of you that are on the NMO database to hopefully complete the questionnaires to help us develop this profile of what it looks, these symptoms look like in the British Columbia cohort. And we've now received ethics approval. So sort of the timeline for this has looked like we did the conversation in July through December, where we July through September, where we talked to the team, we wrote the grant, we submitted and gained ethics approval. In October, we prepared the packages, and with the support of the NMO research team, we sent those packages out to you. And in November, we have now started receiving our first questionnaires back, and to date we've received 11, and that's going to be the basis of some preliminary results. Now 11 is a very small n, but if you look at the NMO research in this field, the n is anywhere, or the number of people that have participated in the study is anywhere from 7 to about 70. So the 11, I hope to have 30 or 40 people responding to this questionnaire. So even reporting 11 is in keeping with how the literature, the state of the literature right now. So let me tell you a little bit about the 11 that have responded to this study. We can see that the majority are female, which is consistent with this disease. It's a bit of an older group. The mean age is 55 for this group. And that's because we have about 5 people in the group that are between 60 and 66. The majority are married or living common law, 90% are. And about 75%, in terms of the living situation, about 75% of the group is living with others and are not requiring any care or assistance from the people that they are living with. There are 3, however, that do require assistance from people that they're living with. I think the employment situation is very telling. 4 are able to be employed, only 1 full-time, 2 part-time, and 1 seasonal. The rest are not, and 2 did not report. About their health, they've had NMO for about 9 years. And in terms of comorbidities, now what that means is it's having another disease in addition to NMO. And about half the group indicated that they had 0 to 1 other diseases or conditions, but about half the group indicated they had 2 or more, up to, and 1 person described up to 8 additional conditions. This is very interesting because when I compared this information with the data from the normal population, about 25% in the same age group have 2 or more conditions. where in NMO, it's about 50%. So it appears that, at least in this very small little cohort, that those with NMO seem to be exposed to chronic conditions at about double the rate of the normal population. And I was a little bit, Denise and I had this conversation about whether I should actually include what is bubbling up as the major comorbidities that were identified to date. It's a little bit early when you have such a small group to start doing that, because just another 5 or 6 can change the order. But to date, the 4 that bubbled to the top were urinary tract infections, mental health conditions, reduced cognitive function, and thyroid problems. But I think that will change. I think we have a very small number right now. So now let's talk about the fatigue. What was very interesting in this in these results is that 65% are reporting that fatigue, they have fatigue, but it varies over the course of the day. So it's really hard to pin it down. This is very interesting. It's quite different than MS, unless it's managed. It's managed differently. It also reported is that there's physical, mental, and emotional fatigue, with physical fatigue dominating. But again, the cohort's quite small. I don't expect it to add up to 11, these numbers, because people will report that they experience more than one type of fatigue. What's very interesting is that the majority, 80%, feel that they can manage their fatigue. So I would suggest that the volume of fatigue that this cohort is experiencing is quite manageable. They don't have the severe fatigue, which is exactly what emerged in our data to date. The severity of fatigue ranked from 0 to 4. The mean was 1.5. That's really on the no fatigue. You still have fatigue, but not really severe. But of those that do have severe fatigue, at the very last line there, 5 had severe fatigue. And I'm wondering if really indeed what the NMO populations going to end up saying to us is that really it's only about 40% of us that actually have severe fatigue, where in multiple sclerosis, it's 80%. But I think NMO and the experience of fatigue is quite different. So if we look at mood for this group, that there is some changes in mood, but as you can see, 10 or 90% feel that they're managing the mood. So again, I would argue that it's not at a substantive level, and that self-medicating is not really a preferred method of managing mood, as a very low number is using that. You can see that the severity of depression is also very low. In fact, what was demonstrated is that really only one individual responded that would meet the criteria for being depressed and should be seeking additional treatment. In terms of anxiety, the numbers look different. There seems to be more anxiety than depression. Where 80% are identifying minimal to moderate depression, where this was the reverse numbers in the anxiety than depression. And the impact is also about 50%. Depression, it was not quite that high. I think our numbers are too low yet to be able to determine really the magnitude or the total volume of anxiety. But I do think anxiety in NMO is going to emerge to be a slightly more problematic issue than depression. So when we move to pain, the scale that we're using asks about regular aches and pains. So none of us travel through life without having some little bobos or little stiffnesses or aches and pains. And so this questionnaire asks about those normal aches and pains, because we want to eliminate those and talk about the ones that are related directly to the NMO. So 80% were able to identify that, yes, they have normal aches and pains, and that the severity of those aches and pains are not that great. But for the majority, but half or just under half, 45%, did identify moderate to severe pain. And that's indeed the group that Dr. Rebai was talking about, and is, I think, really important that we support and provide as much intervention that will remediate that really difficult experience. So that's some of our early data in this particular study. And as I say, by the end of the study, I really hope that we have a much larger pool of information that really characterizes these entities in NMO in British Columbia. What is not presented here are a number of comments that people provided to us. We just simply didn't have the time. Frankly, we received our last survey Friday morning, and we included it here. So we just didn't have time to synthesize the comments, but the comments are also very rich and are really telling us a lot. So I hope to have those results. I hope to have the study finished in 6 months and then have that available for your information. Again, if anyone is interested in participating in it, Denise, do you want to wait? Denise is here to and has questionnaires. If you have received a questionnaire, please fill it out. If you're interested, we very much would like your information to support and provide us with some understanding of what these 4 problems, how they present in NMO in British Columbia. So, having skated over those 4 invisible symptoms and a little bit of data around the study that we're doing right now, I want to thank you very much for your attention and happy to take any questions.
So, I think the important message around research is research gives us some of the answers and knowledge to help improve care. I think this body of work is really important. So please, if you can, participate in the questionnaire. It could really help inform us and improve the care we could potentially provide. So, and there'll be opportunity at lunchtime as well to ask Sue about her life, her career, and about her study. And Denise has the box of the forms there, and I think there's some outside as well. So thank you very much, Sue.
Thank you.
Great. And so 2 more very short presentations to finish off the morning. We wanted to always highlight, whenever we can, some of our young researchers. I used to be, it's Lisa, not me. Lisa joined us a while ago as an undergrad student involved in some of our early research activities, and she's applying to go to medical school. We hope she'll get into medical school and contribute to NMO care in the future. But in the meantime, we're keeping her busy with MRI-based research in NMO. So Lisa, and she's also one of our main volunteers today.
Well, thank you so much for coming, everybody. So today I'm going to talk to you about some of the advanced MRI that's going on at UBC, especially in particular for NMO-SD patients. So conventional MRI is the typical clinical MRI scans that you probably have reviewed with your neurologist before. So some questions that people ask me is, why is this not good enough? Why do we have to look further beyond and look at these non-conventional or advanced MRI imaging? So to answer that question, of course, the conventional MRI is really useful for clinical diagnosis of NMO-SD and also for managing some of the potential devastating symptoms that could come with this disease. And it also shows the lesion distribution in space and time, so it's a very qualitative measure. But the problems are that it's not very specific. So that means that it has limitation in describing the degree of tissue injury. And also it's not sensitive to, for example, diffuse damage in the normal appearing white matter. Also, there are some limited association with clinical status. So that means that just because you may have 10 lesions on your MRI scan doesn't necessarily mean that you're more disabled. So looking at the advanced MRI, this allows to gain better understanding of the tissue injury, including demyelination, axonal injury, and metabolic consequences. So it provides better insight into the pathophysiology of NMO-SD and also better insight into the efficacy of treatment as well as the disease progression. And we're always interested in comparing between MS and NMOSD with these measures, and I will explain further in this slide. So NMO is now officially called NMOSD ever since the new criteria came out back in July 2015. And as many of you guys might be aware, it's more optic neuritis and longitudinally extensive transverse myelitis are very common in patients with NMOSD. It used to be known as a subtype of MS. At one point, it was also called Asian MS, but that is no longer the case, especially after the discovery of aquaporin 4 channel immunoglobulin G, which is also known as the NMO antibody. So some of the challenges that we have is regarding differentiating between MS and NMOSD, because even now, some of the clinical symptoms do overlap for relapsing remitting MS and NMOSD, which means that some patients may be misdiagnosed. And this is really important because the prognosis and treatment options are different. So if somebody has NMOSD and the person is treated with the traditional MS immunomodulant therapy, it may not be effective, or it may even worsen the disease. So these are some of the advanced MRI that's going on at UBC, some of which I have personally been involved with, and some of which it's also new to me. So firstly, the diffusion tensor imaging, it shows the neuronal and glial integrity, and the cortical thickness shown on your right side. It's relevant for NMOSD as well because cortical thinning is known to occur in NMOSD. And in fact, our collaborators in Korea just published a paper this year, which reported that in the NMOSD cohort, the cortical thinning was evident, but it was not associated with cognitive functioning. However, in the relapsing remitting MS cohort, the cortical thinning was even greater than the NMOSD population, and it was associated with memory function. Spectroscopy on your left side at the bottom image, it measures the concentration of brain metabolites such as NAA, which is associated with neurons and oligodendrocytes, glutamate, the neurotransmitter, and the creatine, which is associated with energy storage, and much more. And the frequency shift imaging, it is affected by myelin, by tissue microstructure, by iron. One good thing about it is that sometimes some lesions that can't be detected otherwise because it may be super close to the veins or something like that, it is well visible on this scan. And the resting state fMRI, it looks at the functional imbalance between the brain networks. Out of everything, what I focus on the most is the myelin water imaging, which is actually developed and pioneered by one of our researchers, Alex McKay, here at UBC, still working with us. So the myelin water imaging, it's a quantitative, non-invasive tool that measures the myelin content in various neurological diseases like NMOSD. So before I even go further, in case somebody's not familiar with what myelin is this fatty substance that coats around the axon. And it's really important in the transmission of information. So if the myelin is damaged, then the axon gets exposed and it's more prone to damage. And if the axon is cut off, then it loses the ability for the nerve cells to communicate with each other. And that's potentially what's causing some of the symptoms in NMOSD patients as well. So we calculate something that's called myelin water fraction, which is the ratio between the water trapped in between the myelin bilayers to this total water content. So the total water content, the three main reservoirs we look at is the cerebrospinal fluid, the intra-extracellular water, and of course the water in between the myelin bilayers. And this can be used as an in vivo marker of pathological changes in demyelinating diseases. So when I come to work, these are some of the images that I get to see. So in the middle, what we have is the whole brain 3D gradient and spin echo sequence. And it's a long name, but the important part is that it is used to create the myelin water fraction map, which is shown on the right. And what I can do is I can pick out which brain regions that I'm particularly interested in looking at, like I did on the left side, and grab those values out, so myelin water fraction value. So it tells me how much myelin, 20%, 10% myelin, how much it is in that particular region. And of course, for any research, collaborative work is always important because it allows us to share the ideas and potentially it also provides us with bigger data sets. So this is a collaborative research that I got to take part in. This is with Dr. Jackie Pallas's group in Oxford, United Kingdom, and with Dr. Trabulsi's team here at UBC. So the main finding was that they found the widespread diffuse damage in the normal appearing white matter in MS cohort, which was not evident in NMO-SD. One of my colleagues, Anna Combs, looked at this further, and she looked at the cervical cord of these cohorts. And what she found out was that both in NMO-SD and MS at baseline, there was less myelin content and less volume in cervical cord. However, over 1 year, the cord atrophy was only seen in NMO-SD population. I looked at the subset of this database, and I looked at the brainstem and the corpus callosum, because corpus callosum, it's kind of still controversial in NMO-SD. It is known to be affected, typically affected in MS, but not so much in NMO. What I observed was that in both of the regions, at baseline and over 1 year, in both NMO-SD and MS, the myelin content decreased. But it might be because the sample size that I was looking at was small. So what I want to do in the future is looking at this again, but with a bigger data set. And speaking of the bigger data set, we also are currently collaborating with Dr. Ho Jin Kim's team in Seoul, South Korea. And out of all the research projects that we're doing, one of the really interesting one is this machine learning that Dr. Trabulsi briefly mentioned at the beginning today. So the idea is that even though this anti-aquaporin for a biomarker is useful in distinguishing between MS and NMO, it's specific, but it's not sensitive. So that means that if you test seropositive for this antibody, almost guarantee that you do have NMO-SD, but even if you have this disease, you may not test positive. So it's not sensitive. And in fact, the reporting sensitivity is 76%. So this differential MRI features are highly desirable as an additional tool for accurate and prompt diagnosis. So this is a project that we're currently working on, and we believe that this deep learning has the potential for identifying these visually indistinct brain MRI features that are more sensitive to differences in NMO-SD and MS in advanced MRI imaging. And that's it. These are some of the people that I got to work with either through NMO program or through MRI research. Thank you.
Any questions for Lisa? Any questions?
Sorry, I couldn't hear. Are you talking about the machine learning at the very end? We also have other MRI researchers. We have Irene and Amel. If you guys have answers to the questions, please feel free to answer as well.
You can scream like you're at a Trump rally, and then everyone can hear you.
Like artificial intelligence, using that in order to be able to better distinguish, I guess, NMO, SD, and MS. So what happens with the machine learning is that they'll take sort of all these images, they'll figure out what features of these images, and that's all a bit fuzzy, especially in my mind too. What features are sort of the most relevant for distinguishing the two conditions? So it is kind of like an artificial intelligence type of thing, where they just put in all the information and they kind of figure out, I guess maybe they're looking at where lesions are or how big they are, sort of these sorts of features, and then figuring out if they can distinguish the two conditions. Yes? Okay.
Yeah, in particular, what our team is currently looking at, they're combining these two techniques. So what we found out was that certain brain lesion patterns in NMO, SD, and MS are different. So we're using that technique as well as this another advanced MRI imaging technique called DTI, diffusion tensor imaging. There are certain findings that are distinct between MS and NMO-SD. So by combining those two techniques together, we're trying to create this deep learning program.
Thank you very much.
Thank you.
So I'm the last thing standing between you and lunch. I'm Robert Carruthers. I'm one of the other neurologists here. So I just want to give a very brief update. So there's a few things we wanted to talk about in terms of ways that people can get involved here. One is that CIRCLE study, which is organized by the Guthrie-Jackson Clinical Foundation. We have 40-odd people in it, and enrollment is presently closed. But if people are already a part of the study, we'd be delighted to have people come in and have additional visits so we can gather more samples for the researchers. And this is really aimed at looking at genetic risk factors for developing NMO and even trying to predict whether or not people are going to have a relapse. So that's a very important study. The other major effort that's underway, in addition to things like what Dr. Forwell and Lisa Lee are talking about, is our clinical trials. When we were first starting to enroll patients in the clinical trials, people were saying, well, we kind of expect that any center in the world that has some NMO patients would probably enroll maybe 1 or 2 patients in one study. And right now we have 2 clinical trials running with a total enrollment of 8 patients, which I think it's very important that we're making a large contribution overall to having medications approved for NMO. So thinking that, that's obviously, it's important, it's coming down the line. But the other thing that we had in 2014 here at the Patient Day was we passed around a petition of NMO patients to sign to try and get better access for rituximab. And I'm very pleased to say that after the last NMO Day, we engaged Dennis Chan. He's a pathway, they call it Pathway Advisory Consulting Group, to try and engage the pharmacare in understanding why it is that we need to have access for this medication. And so this has been a multi-step process where Tony and I sat down and reviewed the data to say, well, who is it that really needs to have access to this rituximab? So we put that together, and then we sort of said, well, how many NMO patients are there in British Columbia? And then how many of those people are going to present with these types of symptoms? And we actually put together, it sounds very nerdy, but we put together a very dynamic spreadsheet to understand how many people would need it, and thus we were able to put together a budget and go with that to the provincial government. And I'm very impressed to say that Tony went over there, and maybe you can add your 2 cents, but it sounds as though they were very keen to work with us to meet the needs.
Finally, thumbs up. We're waiting.
Yeah. So that's actually very encouraging for us to see that, if we're advocating for our patients, we're able to move things forward. I mean, obviously it takes time, but this is really important. So that's another important thing. And then the last, in terms of research, there's been nothing terribly earth-shattering in the last year. One interesting study that came out of the Mayo group, led by Sean Pittick, is actually very interesting in that it estimates that in the U.S. there's 16,000 to 17,000 patients with NMO, which if you extrapolate that to Canada to say, like, well, is it going to be a similar number of people having NMO in Canada? Well, maybe not, because the populations are slightly different. But if you just kind of make that assumption, you'd predict that there would be about 1,600 patients to 1,700 patients in Canada. And then because we have 4.6 million people in British Columbia out of 35 million in British Columbia, then ends up being that probably you'd predict about 210 patients with NMO here in British Columbia. We don't have that many people in our database, but I think we'll eventually get closer and closer. But it's sort of an interesting thing that they actually they had underpredicted in the past how many people would have NMO, and maybe this might suggest that it's slightly more common than we had anticipated. So in their data set, it's about the prevalence of the disease. It's going to be around 3 or 4 people in 100,000. So that's slightly higher than the numbers we've been quoting in the past. So yes, there's. Have you guys heard about the anti-MOG antibody? So it's got a checkered past. Basically, like MOG is this myelin associated myelin oligodendrocyte glycoprotein, which is similar to one of these myelin peptides. It's a long story, but in any case, antibodies to this can actually now be tested for in patients who test negative for the NMO antibody. So I'm not sure if there are patients who have a seronegative NMO, but this is something that's recently become available, and maybe that's something that you can discuss at your next clinic visit if that applies to you. So that's my update. I don't have anything else to say except please enjoy lunch, and thank you very much for being here.
I just have a quick thing to say, sorry. We did hand out some evaluation forms. Your feedback is very
The other group will be in here, right?
In here,
Which
yeah,
are
we'll
up
be
front.
back in here, okay? And you'll look at the lunch, we put labels, there's tuna, there's everything, different toothpicks, different colors. There were 2 people who had dietary restrictions. You'll see somebody holding a box, and they're specifically labeled with your names on them, if you let me know that you did have dietary restrictions, okay? Thank you.
So I just want to say thank you all very much for being here. Thank you to our volunteers and to our research team, and particularly to our lecturers for their time and dedication. And thank you very much to Michelle Eisner for her leadership in running a superb program each and every year. So thanks.
Thanks.